You are sitting in the exam hall.
Right.
The examiner hands you a clinical vignette, a middle-aged woman presenting with a locked finger.
A classic.
Yeah, totally classic. So you read the symptoms, you confidently look up, and you say the word tenosynovitis.
Oh, yeah.
And just like that, you have failed the station.
Instantly. Yeah, that is exactly the scenario you need to be prepared for.
Today, we're exploring exactly why that one single word is a fatal trap on your boards. We're bypassing the fluff.
Absolutely.
Today's mission is a rapid-fire question and explanation revision deep dive. We're covering the management of two highly tested, often misunderstood conditions, trigger finger and DeQuervains disease.
Because as plastic surgeons, our goal today is to guide you through this high-yield exam material.
Right.
Every single detail, every anatomical landmark, and every surgical pitfall we discuss today is strictly factual. It's rigorously vetted and directly relevant to your FRCS board exams.
They don't want vague approximations, do they?
No, they don't. The examiners want to see that you understand the precise mechanical pathways.
Okay, well, let's unpack this. Before we even look at the individual diagnoses of trigger finger and DeQuervains, we have to start with the most common fundamental trap.
The terminology trap.
Yeah, exactly. The trap that candidates fall into regarding the pathology itself.
So how are miscellaneous tendinopathies like these typically and mistakenly classified by examinees?
It is incredibly common for candidates to wrongly label these as inflammatory conditions.
Right, because of the swelling.
Exactly. When they see a swollen finger or a painful wrist in a vignette, their brain just immediately jumps to inflammation.
Which makes sense intuitively, but
But it's wrong. As you mentioned in your opening scenario, you'll often hear candidates incorrectly refer to these conditions using terms with the suffix itis.
like tenosynovitis.
Yes, like tenosynovitis.
And why is falling into that specific terminology trap such an absolute deal breaker for an examiner?
Because pathologically, neither trigger finger nor DeQuervains disease are associated with inflammatory cells at the site of pathology.
Right, zero inflammatory cells. Zero. If you tell a board examiner that you are treating an inflammatory process, you have instantly demonstrated a fundamental misunderstanding of the actual disease process.
You're essentially treating the wrong mechanism.
Precisely. You're treating something that isn't there.
That is a massive distinction for you to memorize right now. I like to think of it this way. This is a mechanical traffic jam rather than an engine fire.
Oh, that's a good way to put it.
Yeah, right. Like, there is no fire under the hood. There are no inflammatory cells rushing to the scene with sirens blaring.
Exactly.
But I've got to push back on this. If we rule out inflammation entirely, what exactly is causing that classic clinical presentation? Like, let's talk about trigger finger first.
Okay, sure.
What precisely defines that presentation when it shows up in a question stem?
Clinically, trigger finger describes a very specific popping or snapping sensation as a digit is put through its normal range of motion.
Right, the trigger effect.
Yeah. And crucially, this mechanical catching is not just a painless click. I mean, it is often associated with significant pain.
And locking, right?
Yes, actual physical locking of the digit where the finger becomes completely stuck in a flexed position and requires real force to straighten out.
I always found the demographic data really interesting here because the boards will always paint a picture of a specific patient.
I absolutely will.
Who is the classic demographic they're going to describe in that exam room?
You are looking for a vignette featuring a middle-aged female.
Okay, middle-aged female.
Yeah, it's an exceedingly common condition.
Yeah.
And the predominant demographic is firmly middle-aged women. So if you see that profile, your radar for trigger finger should immediately activate.
And if the vignette asks you to identify the specific digits most at risk, like what's the anatomical hierarchy you need to know?
The thumb is the most frequently affected digit by a significant margin,
The thumb.
followed by the ring finger. That's the next most common digit to be involved.
Okay, so let's summarize that. We have a middle-aged female popping, snapping, and locking in the thumb or the ring finger.
Yep.
And absolutely zero inflammatory cells at the site.
None whatsoever.
Now that we've established that the issue is fundamentally a mechanical traffic jam, let's look at the exact anatomical mechanism creating that jam. What is the exact pathogenesis of trigger finger?
The entire pathogenesis comes down to one word: impingement.
Impingement.
Specifically, it is the impingement of the flexor tendons as they attempt to pass through a narrowed A1 pulley.
Okay, I need to push back on that for a second to make sure we're crystal clear.
Sure.
If there is now inflammatory swelling causing the tissues to puff up, how exactly does that narrowing happen? Like
It,
physically?
well, it's driven purely by mechanical wear and tear. You have to visualize the anatomy here.
Okay.
The flexor tendon is sliding back and forth through a fibroosseous canal. Repetitive loading and friction cause a physical thickening within the substance of the tendon itself.
Wait, the tendon itself thickens?
Yes, and also within the flexor sheath surrounding it.
Oh, wow. Okay.
And in addition to that thickening of the moving parts, the tunnel itself changes. This process is frequently related to degenerative changes occurring around the metacarpal head. Those degenerative bony changes physically lead to a narrowing of the canal.
That paints a perfect picture. The fibroosseous canal is basically a rigid tunnel made of bone and dense fibrous tissue.
Right, it doesn't give.
It refuses to stretch. So the tunnel is getting narrower due to bony degeneration, and the structures passing through it are getting thicker due to repetitive loading.
Exactly. It's a perfect mechanical storm where the physical volume of the contents exceeds the capacity of the container.
Okay, so what is the standard treatment protocol when this locked-up patient sits down in your clinic?
The first line of treatment is surprisingly straightforward and honestly highly effective. Most patients respond very well to 1 or 2 steroid injections
Administered where exactly?
directly into the flexor sheath.
But as a safe surgeon, you must always consent the patient for risks. And examiners love to test you on complications.
You really do.
So what is the rare but exam-critical side effect of this localized injection that you absolutely must warn the patient about?
You must explicitly warn them that rupture of the tendon or rupture of the flexor sheath is a rare but documented side effect of the steroid injection.
Really? A rupture?
Yeah, I mean, you are introducing a potent substance into a tightly confined, mechanically stressed area, so structural compromise is a real risk.
And if we fall into the minority where those 1 or 2 steroid injections just fail to resolve the popping and locking, what's the next step on the surgical algorithm?
Failure to respond to steroid injections requires a physical, surgical intervention, specifically an A1 pulley release.
So you just cut it open?
Right. You go in and surgically divide the A1 pulley to open up the roof of that narrow tunnel, which relieves the impingement entirely.
Now, here is where it gets really interesting for the boards, and this is a classic trap scenario I want you to pay close attention to.
Oh, yeah, this is a big one.
Let's say the examiner gives you a patient who has a known background of rheumatoid arthritis, and they present with secondary triggering. Because we know secondary triggering is frequently seen in rheumatic diseases, right?
That is, yes.
Is an A1 pulley release still your standard fail-safe if the steroids don't work?
Absolutely not. This is one of the most critical high-yield caveats you will face.
Why not?
Performing a standard A1 pulley release in a rheumatoid patient is extremely dangerous because it can severely exacerbate ulnar drift.
Let's explain the mechanics of why that happens. Because memorizing a fact is useless if you don't understand the physics behind it.
Agreed.
In a normal hand, the A1 pulley is just a tunnel roof. But in a rheumatoid hand, the connective tissues are already fundamentally compromised, right?
Yes, highly compromised.
So that A1 pulley is actually acting as a crucial mechanical restraint. It's like a seatbelt keeping the flexor tendons aligned over the joint.
That's a great analogy.
If you slice that pulley open, you remove that seatbelt, the flexor tendons will bowstring.
Exactly. They will take the path of least resistance.
Pulling all gnarly, right? And physically dragging those already unstable fingers into a severe, crippling ulnar drift.
It's devastating for the patient's hand function.
So if you are staring at this rheumatoid patient and you absolutely cannot release the A1 pulley, what is the preferred surgical option?
For these rheumatoid patients, excision of the FDS.
Wait, the flexor digitorum superficialis tendon?
Yes, excision of the FDS may be the preferred surgical approach to resolve the triggering.
I love the mechanics of that. It's such a brilliant, counterintuitive solution.
It really is.
Instead of opening the roof of the tunnel by cutting the A1 pulley and losing that vital structural restraint, you simply remove some of the physical volume inside the tunnel.
By excising one of the redundant tendons.
Yeah, you clear the traffic jam by permanently removing half of the traffic rather than tearing down the bridge.
Precisely. It thoroughly decompresses the fibroosseous canal while completely maintaining the structural integrity of the A1 pulley.
Which they need.
Desperately. That specific rheumatoid patient needs that pulley intact to prevent worsening joint deformity.
That is an incredible detail for you to keep front and center in your revision notes. Now let's transition.
Okay.
We just looked at how a mechanical bottleneck on the palm side of the hand causes the fingers to lock up.
The flexor side, yes.
But the hand is an intricate pulley system, and the back of the wrist has its own high-friction choke points. Let's move from the flexor side over to the extensor side of the wrist and thumb.
To examine our second mechanically induced tendinopathy.
Exactly. What exactly defines DeQuervains disease?
DeQuervains disease is defined anatomically as a stenosis of the first extensor compartment of the wrist.
And for the sake of uncompromising anatomical precision, which is exactly what the examiners demand, which specific tendons are housed within that first extensor compartment?
The first extensor compartment contains the EPB and the APL tendons.
So that's the extensor pollicis brevis and the abductor pollicis longus.
You've got it. Those two exactly.
Just like with trigger finger, the boards will paint a picture of a highly specific patient demographic for this condition. Who are we looking for in the vignette?
Again, you're generally looking at middle-aged women. However, a highly specific, notoriously tested demographic for DeQuervains is postpartum lactating mothers.
Oh, really? New mothers.
Yes, they are very frequently affected by this specific stenosis.
Which leads us perfectly into the how and the why of the pathogenesis. What exact mechanical action drives the stenosis in this first compartment, especially for a new mother?
It is thought to be caused by repeated thumb abduction combined simultaneously with an ulnar deviated wrist.
Let's visualize that biomechanics for a second. Think about the physical mechanics of picking up a newborn infant from a crib dozens of times a day.
It's exactly that motion.
You drop your wrists down toward the pinky side, that's your ulnar deviation. At the same time, you stretch your thumbs out wide to support the baby's head and torso.
That's your thumb abduction.
You are pulling the tendons tight while bending the tunnel they run through. What does that specific repeated movement pattern do to the local anatomy over time?
It generates immense localized friction. And that friction occurs right at the opening of the retinacular sheath.
Makes sense.
Over time, that constant rubbing leads to physical swelling of the tissues and a progressive narrowing of the fibro-osseous canal.
And again, we must emphasize, this is mechanical friction causing structural swelling.
Not an autoimmune inflammatory response.
Yeah.
Exactly.
So how is it diagnosed clinically when this patient actually sits down in your examination room? I mean, you aren't immediately ordering an MRI, are you?
No. Diagnosis is primarily clinical. It's based on a patient history of radial wrist pain.
So pain right at the base of the thumb.
Right. And crucially, this pain is actively exacerbated by thumb movements. On physical examination, you may also visually observe and physically palpate a tender swelling located just proximal to the radial styloid.
But there is a very specific, provocative clinical test you absolutely must know to confirm this on the exam.
Finkelstein's test.
Yes. Can you detail the exact mechanics of Finkelstein's test?
Yes. Finkelstein's test is the classic provocative maneuver for DeQuervains. To perform it accurately, the patient's thumb is pulled into ulnar deviation while simultaneously placed under longitudinal traction.
So you are basically forcing the exact mechanical posture that caused the injury, but under tension.
Yes, severe tension.
The clinical response to this test is so dramatic, it's highly memorable. Is it true that patients actually anticipate the severe pain and physically react before you even finish the movement?
It is absolutely true. And it is a classic hallmark you should vividly visualize for your exams.
Really? Like they actually jump?
Yeah, the affected patients anticipate the severe pain so acutely that they will literally begin to jump or get out of their chair as the thumb is moved.
Wow.
The sudden tension placed on those already stenosed tendons within that extremely narrow, unyielding compartment is exquisitely painful.
The jump out of the chair sign, it is visceral. If you see that described in a question stem, or if an examiner asks you how to confirm the diagnosis clinically without imaging, Finkelstein's test is your gold standard answer.
Absolutely.
So once the patient is diagnosed via this test, we must transition into the treatment pathways. Let's start with the non-operative options.
Okay.
If a patient is terrified of needles or surgery and asks for just a splint, we need to be direct that it's just a temporary fix, correct? The symptoms will recur.
That is correct. Splint immobilization is a non-operative option, but you must understand and you must explain to the examiner its limitations.
Which are?
It is effective only while the splint is actually in situ. It merely pauses the mechanical friction.
Because the wrist isn't moving.
Right. Shortly after the splint is removed and normal mechanical loading resumes, like going back to lifting that baby, the symptoms will inevitably recur.
So a splint is essentially just pausing the disease process, not resolving the underlying structural mismatch.
Correct.
What about steroid injections for the first extensor compartment?
Steroid injections are far more definitive as a non-operative treatment for DeQuervains.
How effective are we talking?
Administering steroid injections into the compartment leads to a complete resolution of symptoms in up to 80% of cases after just 2 injections.
Wow, 80%. That is an incredibly high success rate for a non-surgical intervention.
It is.
But as surgeons, we are tested on what happens when things fail. If we fall into that 20% where steroid injections have failed, operative release of the compartment is indicated.
Exactly.
And this is where the surgical hazards heavily tested on the boards come into play. When the surgeon goes in to cut the retinaculum and release that first extensor compartment, what are the massive anatomical pitfalls they need to navigate?
The critical point you must memorize is that the anatomy of this first compartment is highly variable.
Variable how?
It is rarely just a single, simple, empty tunnel containing 2 neat tendons.
Okay, so what kind of anatomical variations are we talking about when you open it up?
First, there may be multiple separate sheaths and internal septations, physically dividing the compartment into subtunnels.
Oh, wow.
Second, there may be multiple slips of the APL and the EPB tendons themselves.
Let's use an analogy here. It's like you are tasked with clearing a multi-lane highway. You open up what you think is the main road, but you don't realize there is a concrete barrier and internal septation hiding a completely separate lane right next to it.
Exactly. That's exactly what it looks like structurally.
Why is failing to recognize that variability so dangerous for a surgeon who isn't paying close attention?
Because if you do not actively look for, identify, and surgically release all of these separate sheaths, internal septations, and multiple tendon slips, the decompression will fundamentally fail.
So they wake up in pain?
Yes,
Okay.
the patient will wake up from surgery and still have the exact same symptoms, because a portion of the tendon complex is still tightly impinged in an unopened subcompartment.
That's a nightmare.
Every single anatomical variation must be released to ensure a successful outcome.
It requires meticulous exploration, not just a blind cut.
Precisely.
And aside from the risk of failing to release the compartment entirely, what critical adjacent structure is at direct risk of being sliced during this surgical approach?
You must carefully identify and rigorously protect the branches of the superficial radial nerve.
The superficial radial nerve.
Yes. They run directly through the surgical field and are at direct risk during the approach to the first extensor compartment.
And let's be clear about what happens if you get sloppy. Cutting or injuring those superficial radial nerve branches will leave the patient with a painful neuroma or numbness over the dorsum of the hand.
It's terrible for the patient.
Right. A neuroma in that specific area means every time they put their hand in a pocket or brush against a sleeve, they experience shooting electrical pain.
It's a devastating, life-altering complication for what should be a relatively straightforward, superficial decompression procedure.
Exactly. And that is why the examiners hammer you on it. They want to ensure you respect the anatomy and know exactly where the danger zones are.
Which is exactly what we're here to teach.
Okay, let's quickly recap the high-yield takeaways from today's deep dive for your FRCS exam revision.
Let's do it.
First, the fatal terminology trap. Neither trigger finger nor DeQuervains disease are associated with inflammatory cells at the site of pathology. They are driven by mechanical friction and degenerative changes.
So do not ever call them tenosynovitis on your exam.
Never.
Second, remember the rheumatoid caveat for trigger finger? Failure to respond to steroids usually mandates an A1 pulley release.
Right.
But an A1 pulley release in a rheumatoid patient removes a critical mechanical restraint and can severely exacerbate ulnar drift. Excision of the FDS may be the preferred alternative to decompress the space without losing that structural integrity.
That's such a key point. And finally, for DeQuervains disease, diagnosis is confirmed clinically with a positive Finkelstein's test, pulling the thumb into ulnar deviation under longitudinal traction to elicit that jump out of the chair pain.
Yes, the jump test.
If steroids fail, surgical release is indicated, but you must navigate the highly variable anatomy. You must meticulously identify and release all separate sheaths, internal septations, and multiple slips of the APL and EPB to ensure success.
All while rigorously protecting the branches of the superficial radial nerve from injury.
Those are the exact, precise facts that differentiate a passing candidate from a failing one. You need to know the anatomy, the mechanical physics, and the specific exceptions to the surgical rules.
Spot on.
Now, to leave you with a final provocative thought to mull over for your revision tonight, we established right at the beginning, and we repeated it multiple times, that both of these conditions are fundamentally mechanical and degenerative.
Right.
There are absolutely zero inflammatory cells at the site of pathology, so if there is no inflammation to suppress, how exactly do steroid injections achieve an 80% success rate on a cellular level?
Well, a great question.
What is the actual underlying mechanism of action of that steroid if it isn't fighting an inflammatory response? Think deeply about that paradox as you continue your prep.
It's a fun one to research.
Make sure you hit the follow button right now so you do not miss our future revision deep dives. If you learned something today that will help you pass your boards, leave us a rating.
Please do.
And to take your revision to the absolute next level, get a premium subscription to the show. That will unlock exclusive access to our journal club and our complex clinical cases deep dives, which are designed specifically for advanced board prep.
It's totally worth it.
Finally, leave a comment or a question below. We want to know exactly what topics are giving you the most trouble so we can tackle them next. Keep studying, stay focused, and we will see you on the next deep dive.